Good evening. My name is Tyler Kuhn. I'm here teaching my son, Kale Kuhn, about the basic airway management course that I've created for the Level B Instructor. Today we're going to discuss basic airway management. All right. So while we're shooting this, you can see on the second portion of the video the PowerPoint slides that we're also looking at behind us. All right, Kale, so today we're going to learn about basic airway management. You know, I'm your father, Tyler Kuhn. All right, first slide. So right here we have the anatomy of the upper airway. As you can see, the airway is made up of the upper airway and the lower airway. The upper airway includes the jaw, mouth, nose, nasal cavity, the pharynx, and the larynx. Right? Mm-hmm. So you can see on the screen there, we've got the tongue, the epiglottis, and then below there you can see the vocal cords, the larynx, and the trachea. And then behind it, which is the anterior portion, the posterior portion, the nasopharynx, the oropharynx, and the hypopharynx. Right. Today we're going to talk about the upper airway because that's pretty much all we need for this lecture. We have the pharynx, which is broken down into three parts. It's the muscles that facilitate food going down into the esophagus, etc. We have the larynx, which is also known as the voice box. It helps produce sound. It also facilitates respiration and protects the lower respiratory tract. And then we have the epiglottis, which is pictured. I thought it wasn't. It sits just above the larynx, right? And it prevents food from entering both the larynx and the trachea. So it prevents, the epiglottis is a flap that closes down while you swallow. So it prevents food from going to your lungs. So today we're going to talk about opening the airway. We're going to talk about airway adjuncts that we will use when we're opening the airway. So there's two methods of opening the airway. We have the reason we are going to use these two methods for unconscious patients. It'll open the airway to restore patency. Patency meaning it's not closed, it'll be open. So we've got the two pictures on the side, and then we have an explanation on the left. So the first method we're going to talk about is the head tilt chin lift. We only use this when there's no evidence of a neck injury or a C-spine injury. All right. And how we do that is we place one hand on the forehead and the other below the chin, restoring the head to the neutral position. Right. So you put your hand here, and then you put your fingers or your other hand on the chin, and you'll tilt back, and that'll open the airway. All right. The other maneuver we have is the jaw thrust maneuver. This is for if a patient has a neck injury, then we'll use this one. And how we do that is we place the hands on the temporal region. So it would be like placing your hands on this side here with your thumbs facing upward, right? And your fingers placed on the mandible or the jaw, angle of their jaw. You'll lift upwards with your fingers while keeping the neck from moving. And this will separate the jaw from forward, and it'll allow you to open the airway. And that'll go on to our next slide, which we'll talk about the adjuncts we use. It make sense so far? Mm-hmm. Okay, perfect. So we have two different types of airway adjuncts that we will use. These are utilized to open the patient's airway in conjunction with the head tilt chin lift or the jaw thrust maneuver. The use of the airway adjuncts for an unconscious patient, a semi-conscious patient, and it also helps facilitate bag valve mask ventilation, BVM, in short.
So like that thing that you put in the mouth, and then there's a
and there's a bag on the top, and we'll discuss that as well. The contraindications or reasons why you would not be able to do this. For an NPA, you would not be able to use this if the patient has severe trauma to the head or face. Because if you stick the NPA in, if there's a facial fracture, it runs a risk of pushing it into the brain. For an OPA, so NPA is a nasal pharyngeal airway, OPA is an oral pharyngeal airway. The OPA contraindications would be a conscious patient or a patient with a gag reflex. So if I stick the OPA in your mouth and you start gagging, then we're not going to use that. Make sense? Mm-hmm. Right, perfect. Moving on. So we're gonna move on to the NPA, and in the picture, you can see how they're measuring it. All right, so that you'll measure from the tip of the nose to the patient's earlobe. All right, that'll give you a correct measurement from the nasal cavity down to the back of the airway. And the way we insert this is we're gonna first lube the NPA, and then we're gonna insert with the bevel facing the septum. So you're gonna go on the right nostril, the bevel facing in. The right nostril is generally bigger than the left, so we'll try that one first. If you have issues in the right nostril, swap over to the left nostril. And then we're going to insert with the bevel facing the septum, and then we're going to advance along the septum following the natural curvature of the nasopharyngeal cavity. The NPA, as you put it in, will rotate about 90 degrees, and then the flange, the little piece on the top, will rest just in the nair. Make sense so far?
So is the NPA for like people that are awake, or no, that are like unconscious?
Yeah, without any sort of C-spine injury or neck injury. And this will be for like if a patient overdoses and we need to use the BVM to ventilate them, then we'll stick one of those in there so that way if the tongue's flat back on the airway, we can remove the tongue. The next one we're going to go over here is the OPA, the oral pharyngeal airway. And I forgot to put the other picture in there. The way we measure that, it's obviously not pictured, is we'll measure from the center of the mouth to the angle of the mandible, or the corner of the mouth to the earlobe. So the center of the mouth being the center opening, down to the mandible here, the corner, or the corner to the earlobe. And that's very important when sizing, because if not, then you can stick too small of one in there and cause an airway obstruction. And so then to insert this, we'll start by rotating the OPA 180 degrees, so it's facing the roof of the mouth. Right, we'll insert in the mouth and twist the OPA 180 degrees, following the anatomy into the posterior lower pharynx. And then the flange, which obviously I didn't put the picture on there, is kind of like T-shaped at the top, and it'll rest on the mouth.
So kind of like that one.
It's similar, but this one, it's a plastic piece, and it's like round. It goes down and then it's round. All right. So pretty similar. This one for if you have a patient with a neck injury or again unconscious, and that'll again open remove the tongue and allow you to ventilate the patient. Lastly, we're going to talk about the bag valve mask and two methods of using the BVM. First, we have the single rescuer, and to do this, we're going to use the C&E method. And the C&E method you can see pictured here is you're going to create a C with your index and your thumb, and you're going to place it over the bridge of their nose, the narrow portion of the bridge of their nose. All right, then you're going to take your three fingers, your middle ring and pinky, and you're going to place it under their mandible, right? And at the same time here, you're going to gently press down on the top portion with your thumb over the bridge of the nose, and then you're going to pull up on the mandible, and that's going to create a seal, right? So it's like, you can see on the screen there's like some plastic that's blown up with some air, and that'll allow you to create a seal so you can ventilate.
Does it like close the mouth?
It doesn't close the mouth because you have the airway adjunct, but it will allow, it's almost similar to like a balloon, and it'll seal around so the oxygen doesn't go out. All right, and then we're going to ventilate the patient once every 6 seconds. So 1, 2, 3. So it's roughly 12 to 16 times a minute.
So with your index and thumb, are you like pushing down and making the seal?
Yep. So you're going to push down here while pulling up on the mandible, and you don't have to push it.
So it doesn't drop.
Yeah, and you don't have to push as much pressure down because you don't want to close their airway. So you don't want to push their head down, especially in children, because if you push down, you'll just collapse their airway here, and then whether or not you have an OPA or an NPA, you're probably just going to push down and close their airway. So you're more so pulling upward and putting a little bit of pressure to pull that together. Make sense?
Mm-hmm.
All right. And then the last thing that we're going to go over is the BVM using two rescuers. So if you and I went to a patient, this would be the method to use if we didn't have to do CPR. And the way we're doing that is we're going to, dang, I didn't put the other picture in there either. We're going to hold the BVM, placing the narrow portion of the mask over the bridge of the nose. You're going to use your palms, and you're going to push the mask down into the patient while using your middle ring and pinky, pulling up on the mandible to create that seal. Right. So then the other rescue will squeeze the bag and ventilate the patient. And then a side note that I placed on here as well is when we're ventilating the patient using a BVM, we're going to squeeze the BVM just enough to see chest rise. Then we're going to let go and watch it fall. Squeezing to the full capacity will inflate the lungs, causing injury. The absolute volume of a BVM is roughly 1,500 milliliters. So the big bag that we squeeze is roughly like 1,500 milliliters of oxygen. The normal person needs between like 350 to 550. It goes based off of your height, not your weight. Does that make sense? Mm-hmm. All right, and this will conclude our presentation today. I've added some references for some pictures, and thank you for joining me today.
Thank you for having me.